Good afternoon and welcome to today's All Tribes call on the Medicaid Managed Care ITU Addendum, sponsored by the Tribal Affairs Division, Center for Medicaid and CHIP Services, CMCS. I am Lane Terwilliger with the Division of Tribal Affairs, and joining me on today's call is my colleague, Rachel Ryan. On April 25, 2016, CMS released a final rule on managed care in Medicaid and the Children's Health Insurance Program, CHIP. This rule incorporated the Indian protections in Section 5006 of the American Recovery and Reinvestment Act, otherwise referred to as ARRA. The Indian-specific provisions in the final managed care rule are located in the section Standards for Contracts involving Indians, Indian healthcare providers, and Indian managed care entities. In the final rule, CMS committed to developing sub-regulatory guidance through consultation on the use of the Medicaid and CHIP Indian Managed Care ITU Addendum. The ITU Addendum is intended to help facilitate contracts between Indian health providers and managed care plans by identifying several specific provisions established in federal law that apply when contracting with Indian healthcare providers. Per an October 5th, 2016 CMS All Tribes call, CMS obtained tribal input and advise on an informational bulletin that the Center for Medicare and Medicaid Services is developing that highlights the Indian-specific provisions of the final rule. We indicated on that call that we would hold a separate call on the ITU Addendum. CMS will then release the informational bulletin and the ITU Addendum as a single guidance together. And after following this call, the link to the ITU Addendum will be sent out to everyone who participated. It's on our Spotlight page. At this time, I would like to provide an overview of the purpose of the ITU Addendum and walk through key provisions. Purpose. Similar to the standardized contract addendum used for the qualified health providers in the Medicare Part D program, this addendum has been developed for Medicaid managed care entities to use when contracting with Indian healthcare providers. Through the clearance process, this addendum was modified slightly from the model addendum for QHPs to be streamlined and consistent with the final Medicaid managed care rule. This addendum is not required, but CMS received several comments supporting the development and issuance of a model addendum for this purpose to assist Medicaid managed care entities in including Indian healthcare providers in their networks. We anticipate that the addendum will facilitate acceptance of network contracts by ITU providers. We also anticipate that offering contracts that include the addendum will provide managed care entities with an efficient way to establish contract relationships with ITU providers and ensure that American Indian and Alaska Natives can continue to be served by their Indian healthcare provider of choice. Indian tribes are entitled to special protections and provisions under the federal law, which are listed in the addendum. The addendum also identifies several specific provisions that have been established in federal law that apply when contracting with ITU providers. The use of this addendum benefits both managed care entities and the ITU providers by lowering the perceived barriers to contracting, assuring managed care entities comply with key federal laws that apply when contracting with ITU providers, and minimizing potential disputes. Next, I'm going to walk through the key provisions in the addendum. First of all, we have defined both Indian healthcare provider, managed care plan consistent with the regulatory definitions in the final rule. Next, we have the cost-sharing exemption for Indians, no reductions in payment. In this section, we emphasize that American Indian and Alaska Natives are exempt from cost-sharing and explain that managed care entities are prohibited from reducing payments to Indian healthcare providers. These provisions were enacted with the American Reinvestment Recovery Act of 2009. The next section describes the enrollee option to select an Indian healthcare provider as a primary healthcare provider. We also emphasize American Indian Alaska Natives' right to choose the Indian healthcare provider regardless of whether that provider is in the Managed Care Entities Network. This provision was also enacted with the American Reinvestment Recovery Act of 2009. Next, Managed Care Entities Agreement to Pay Indian Healthcare Providers. This provision requires managed care entities to pay Indian healthcare providers regardless of whether the provider is in the Managed Care Entities Network. Next, contract assurance that allows Indian healthcare providers to limit who is eligible for items and services. This section identifies that an Indian healthcare provider can limit who it provides services to under the Indian Healthcare Improvement Act. The next section, explanation of applicability of federal laws to Indian healthcare providers. This provision explains that certain federal laws are applicable to Indian healthcare providers, but not others. Those laws are listed in Appendix A to the addendum. Next section is the explanation that Indian healthcare providers are non-taxable entities. This section explains that managed care entities may not collect or require Indian healthcare providers to remit taxes. The next section is an explanation that Indian healthcare providers are not subject to insurance requirements, including professional liability insurance. This provision of the addendum explains that Indian healthcare providers that are subject to Federal Tort Claims Act are exempt for insurance requirements. The next section is explanation concerning licensure, accreditation, exemption for Indian healthcare providers, including professional staff and the facility. This section explains that managed care entities may not subject Indian healthcare providers to state licensure and accreditation requirements. The next section talks about dispute resolution and binding arbitration. This section identifies that managed care entities may not subject Indian healthcare providers to binding arbitration in the event of a dispute between the managed care entity and the Indian healthcare provider. The next section is a statement that federal law governs. Indian healthcare providers are not subject to state law and medical quality assurance requirements. These provisions explain that federal law governs in the event of a conflict and will prevail. It also explains that Section 805 of the Indian Healthcare Improvement Act applies to medical quality assurance requirements. The next section explains the claims format. The section requires managed care entities to process claims in accordance with Section 206H of the Indian Healthcare Improvement Act. Next, we talk about the payment of claims. This provision requires managed care entities to pay the applicable payment rate, whichever is higher. Hours and days of service. This section of the addendum explains that the Indian healthcare providers may set its own hours and dates of operation. Next section is purchased and referred care requirement. This section explains that the requirements for purchased and referred care prevail over the managed care entity's requirements when purchased and referred care are used. The next section discusses sovereign immunity. This section advises that by contracting with the managed care entity, the Indian healthcare provider has not waived sovereign immunity. The last section discusses endorsement. The final provision of the addendum advises against using Indian healthcare provider names used to suggest official endorsement or preferential treatment of a specific managed care entity. At this time, I would like to open up the call for any questions and comments. Joanne, operator, could you ask if there are any questions or comments?
No worries, Ms. Terwilliger. Ladies and gentlemen, at this time, I would like to remind everyone in order to ask a question or make a comment, please press star and the number 1 on your telephone keypad. We'll pause for just a moment to compile the Q&A roster. Once again, if you would like to ask a question or make a comment, please press star one on your telephone keypad. Your first question or comment comes from the line of Miss Melanie Forkiller from Choctaw Nation. Your line is open. Go ahead with your question or comment.
Thank you, and thanks, Lane and Rachel, for holding this call. I just wanted to put on the record that we appreciate the work that's gone into this draft addendum, and we had a discussion with you all last week during PTAG subcommittee, and a strike-through version with some recommended changes was presented. And I just want to say for the record, Choctaw Nation endorses that strike-through, and we want to put that on the record. But one of the items I wanted to mention specifically was with regard to FTCA coverage, the section that refers to that. In the current draft, it has a paragraph related to Indian Health Service and a paragraph related to FTCA coverage for tribal organizations. And I just wanted to, we've made some suggested comments or changes to that section. And the reason that we have is because we want to be clear that the coverage for FTCA related to either IHS or tribes, it should be the same, and it should be stated as equally as strongly in the tribal paragraph as it is in the federal paragraph. So just wanted to put that comment on the record, and we've made a suggested change for that. We understand that that one of the differences is that we have a self-determination or self-governance agreement to assume those services from the Indian Health Service, and that's how we get FCCA coverage. But we do believe the definitions at the beginning of the addendum would cover the definition of a tribal organization for purposes of that. So thank you again for hosting this call, and thanks for receiving my comments.
Thank you, Melanie.
Hey, Melanie, this is Rachel. I received a copy of the red line version, but you have not submitted your recommended comments yet, right? We didn't miss that.
Not specific to Choctaw Nation. I just wanted to say that we support the red line.
Okay. Do you know? Okay.
Great.
Thanks.
Thank you.
Yeah.
Once again, I would like to remind everyone, in order to ask a question or make a comment, please press star then the number 1 on your telephone keypad. So no further questions or comments from the phone lines at this time. I would now like to hand the conference back to today's presenter. Please continue.
This is Lane Terwilliger. I was going to wrap up since I don't hear any more questions, and we do appreciate the red line and the support for the red line version from Melanie. Thank you. So as a final reminder, Tribal Affairs is seeking written comments on the ITU Addendum, and those comments are due by close of business November 16, 2016. Please submit written comments to the Tribal Affairs at cms.hhs.gov. Again, please submit written comments to Tribal Affairs, that's one word, at cms.hhs.gov. Thank you again for your participation.
Pardon the interruption, Ms. Terwilliger.
Yes.
Yes, ma'am. We do have additional participants who are going to make a comment or ask a question. Would you like to take them?
Yes, thank you.
All right, thank you. So your next question or comment comes from the line of Devin Delro from National Indian Health. Your line is open. Go ahead with your question or comment.
Thank you. Hi, Lane. Hi, Rachel. I just want to echo Melanie's comments and really thank CMS for taking the comments submitted by TTAG and tribes to heart with creating this managed care addendum. And I just want to recommend that you continue to work with the TTAG and tribes in finalizing this. Hopefully at the end of this comment period, NIHB will be submitting some formal written recommendations. But at the end of the comment period, if you could also, any additions or edits you make to the addendum, you share those edits with TTAG, with tribes before the product is actually finalized. Thank you.
Thank you, Devin.
Your next question or comment comes from the line of Elliot Neil Holland from Hubstaff. Your line is open. Go ahead with a question or comment.
Hi, Lane, Rachel. Again, to echo Devin and Melanie's comments, thank you to CMS for working on this addendum and for issuing the sub-regulatory guidance. I think that the managed care addendum will be an incredibly important tool for the IHS and tribes, tribal organizations, and urban programs in contracting with and entering into provider networks in managed care settings. I would like to make one comment and ask one clarifying question, if I could. On the managed care addendum, there is a section entitled "Purchase Referred Care Requirements" that then states, I think very positively, that the provider may make, the provider, which is really the Indian healthcare provider, may make referrals to other in-network providers, and such referrals shall be deemed to meet any coordination of care and referral obligations of the managed care plan. And that's consistent with what CMS put out in its new managed care regulations, and I think that will go a long way to avoiding scenarios in which an individual Indian Medicaid managed care enrollee would have to seek primary care, for example, at an Indian healthcare provider, and then go seek the same primary care at a managed care in-network managed care provider, simply in order to be referred up to a specialist. That would create a burden on the individual Medicaid enrollee, and also a burden on the Medicaid system in an unnecessary duplication of care. So we think that first sentence is very important. I think that the second two sentences, the second and third sentences there, are really designed to kind of assist with purchase referred care issues, and to the extent that kind of looking at this again, the tribal comments are draft managed care addendum that was provided to CMS, entitled this section "Purchase Referred Care," and I think that on further reflection, really it should just reference referral requirements, as purchase referred care programs are payer of last resort, and should not really be implicated in referrals in managed care settings. So it may be neater to simply remove those second and third sentences to that paragraph, and simply have the paragraph reiterate the deemed to meet provisions in the first sentence. So that's my comment. My question, and I think that tribes will be submitting written comments, and thank you very much for the reminder to do so and the information about how they can do so. One question I had was, there was in at least the draft that some tribes had submitted to CMS, had included a provision which would have laid out the requirements that's set out in the ARA stimulus bill, which states that certain trust-related income from things like forestry or fisheries or other types of trust-related income are not to count for the purposes of determining how much income somebody has for Medicaid eligibility purposes. So there was a provision that was included there in the tribal version that was initially submitted to CMS, and that was omitted from the final draft. And it may have been omitted because of the sense that the managed care entities never have a role in making eligibility determinations. We were not sure whether that was the case or not. So I guess that's our question to CMS. Have you been able to confirm whether that's the case? Because to the extent they are assisting in enrollment, they'll obviously be working with the states. But to the extent that they're assisting in the enrollment process, that's an important provision, which really opens up Medicaid to a larger number of individuals, particularly in certain areas of the country.
Thank you, Elliot, for that question. And you are absolutely correct. Managed care entities don't play any role in the Medicaid eligibility process. And so that was the genesis behind removing that particular provision. Individuals that are enrolled in Medicaid and CHIP, that is a state function, a single state agency function. And then after they're enrolled in Medicaid, then they're either assigned or opting into the plans. And so that was the genesis of why that provision was taken out. But I really appreciate your question.
Thank you. I think we'll be submitting further comments in writing as well.
Thank you. We're looking forward to receiving those.
We have your next question or comment coming from the line of Sarah Freeman from National Indian. Go ahead with your question or comment. Your line is open.
Hi, thank you, Lane and Rachel. This is Sarah with NIHC. I just wanted to add a kind of minor terminology additional comment. I'm sure we'll be including them in our written comments that are due the 16th as well. Thanks for all the information. It's definitely clarified a few of our questions. But with regards to change in the terminology for the Indian healthcare provider that you have listed, first in the purpose of the addendum that relates to. So I guess we're just trying to figure out which are the facilities, obviously, that include IHS and tribally operated facilities, but it just seems to not be clear what a network Indian healthcare provider agreement is, just with regards to terminology. We want to make sure everyone's on the same board.
Sure, this is Lane. Could you step back and repeat your question? I want to make sure I understand it.
Yeah, sorry about that. So just with regards to, it's not much of a question, it's more a comment, but with regards to the terminology of the Indian healthcare providers that have been replaced, have replaced provider, I think we need a clarification on what a network Indian healthcare provider agreement is.
So this is Rachel. This might help. So when we were reviewing the addendum at TTAG, somebody expertly pointed out that we had somewhere along in the edit process, somebody had done a word replace for provider at IHCP. So what happened is that there were some places where it should have just said network provider in reference to a provider that was in the managed care network, and it got replaced with network IHCP provider. So we've tracked those spots down in the addendum, and I think we've corrected that. Does that fix your problem, or is that not address it?
Yes, it does. Thank you, Rachel. I wanted to make sure that was taken care of. Thank you.
There's a really good catch. And we only found a couple places, but it was very confusing.
And we do. This is Lane. We really do appreciate all your willingness to respond to this quickly, the TTAG's participation in this, and that we are looking for a quick response, but we really are trying to get this guidance out so we can have the informational bulletin and the ITU addendum kind of go out as a pair. And, now that we have a different administration, it's really incumbent that we work to get these out as fast as possible. I think that there'll be one more little round of clearance internally. So I just want to warn you about that. So we really appreciate your willingness to turn this around fairly quickly. Thank you.
Your next question or comment comes from the line of Angela Wilson from Pitt River Tribe. Your line is open. Go ahead with your question or comment.
Hi, Lane and Rachel. Thanks for holding the call as well, and certainly agree with all the comments that we're hearing on the phone from our colleagues out in Indian country. So we do appreciate the work of TTAC as well. Just a quick comment, really. One of the significant barriers that we run into here in California, Pitt River averages about 27,000 miles a month in transporting our patients to specialty care outside of our managed care entity that we primarily work with, which is Partnership. And when that happens and we cross over to the boundaries of another managed care entity, part of the problems that we're running into is the credentialing process. So when we all of us, ITUs, we enroll with the state Medicaid program, we have to credential at that time. And I guess, my comment would be that tribe should be able to credential with the state Medicaid program and have that credentialing carry throughout all of the Medicaid process, whether it's on the managed care entity side or on the fee-for-service side. The reason that this is such an issue is when we're forced to do separate credentialing for every single different managed care entity, that process causes significant barriers in third-party reimbursement in a timely manner, and also access to care in certain cases when we're really trying to work hard to educate the managed care entities about these referrals from the primary care provider. So it is an administrative burden on the ITUs to have to separately credential with each managed care entity. So that's just a comment on my end.
Right, and this is Lynn. I'd like to respond to that because right now, I know you're in California. It always seems to be our pool of problem areas. We are actually looking into that issue now and going over it with our general counsel and getting clarification. So I think it's kind of a two-pronged problem. It's not only is it happening to you on the ground there, and we agree with you that it shouldn't, but we've got to get the clarification and internally educate CMS internally and also within our regional offices. So we've got a little bit of work cut out for us, but we've heard about that issue, and a lot of times we're also hearing from different regions that sometimes tribes are just agreeing to do things just to get into the network, and so we're trying to get kind of a feel for how widespread this this issue is, whether it's not just in California or it's in other areas, and maybe when Kitty Marks gets back, we might have a discussion on maybe releasing some guidance to the states to remind them what the rules are, because we're hearing that a lot. We're also hearing that some managed care organizations in California are doing like site visits and things too. So we've learned an alarming number of issues going along with the credentialing and licensing, and I think that there's a general confusion on what the requirement is for fee-for-service and whether or not the managed care entities can apply an additional requirements on top of fee-for-service. So we're on that, and I hope that we can get that resolved in your region soon, so more to come on that. But never stop bringing it up.
All right, thanks, Wayne. I appreciate it.
Your next question or comment comes from the line of Carolyn Galp from Red Cliff Indian. Go ahead with your question or comment. Your line is open.
Good afternoon. Yes, this is Carolyn Gouget with the Red Cliff Band of Lake Superior, Ojibwe in Wisconsin. And I work within the Purchase Referred Care Department. And our health center is going through some transitions. And so when I look at this, the Medicaid and CHIP managed care entities with this addendum for contracting, I need to be able to I need to get a 101 on this. First off, our health center, I believe, we have contracts with the state, and we do have work with Medicaid, Medicare. So I'm not quite sure if I'm following you in as far as with purchase referred care. We do need referrals for those that are referred outside of the facility. So I'm trying to see, from my experience, is when we do applications up with individuals for Medicaid, the state will automatically put those individuals in a HMO or a managed care entity, and it's out to the people then to go exempt themselves out of that managed care. So am I following this? Is this what's happening? Is this what the focus of the group is?
Let me address you have a couple of questions in there. Let me address that. In our final rule, and also as part of our guidance that we're hoping to release with this ITU Addendum, we want to kind of point out some options and for states and tribes to work together, or even CMS states and tribes to liaison together to figure out, if they're going to mandate Indian individuals into managed care, then maybe there's some things that they could do better. And we talk a little bit in our rule about algorithms and all, and that's kind of like a foreign object. But we're thinking like on the ground, we've heard some practices. I heard some from the California Rural Indian Health Board that maybe you could put all the Indian healthcare programs into the plans, and maybe the individual could be assigned by a zip code, and maybe that would eliminate the individual's wrong assignment to the wrong provider. And there's been some other kind of strategies. So we'd be happy to work with you in your particular state with your tribes to figure out a strategy, and that maybe we can facilitate a discussion how they could do that better, because we do understand that it's a burden to be enrolled into a managed care plan when you're already using an Indian healthcare provider as your primary care provider. So we do understand that. We'd like to have a discussion offline with you, and like to hear, any kind of best practices you can think of, because when we roll all these provisions out, we want to be able to suggest to state strategies for making this better.
I appreciate that. And yes, I would like to have further dialogue with you on how we can do best practices and work best for the people that we serve within our area. So I guess I could email you and then try to start collaborating and coordinating some of these efforts. So I can understand. So as I mentioned, we're going through transitions at our health center, and I work with the spiritual super camp, so I know that, but this is something that was just brought to me.
Would you like me to provide my email now?
Please. Yes, that would be great.
I'm just going to spell it out. It's phonetic. LANE dot TERWILLIGER at cms.hhs.gov.
All right. Well, thank you, Lane.
You're welcome. We really do look forward to getting some strategies for this, because we've been hearing about it at all of the consultations across the nation.
There are no further questions or comments from the phone lines at this time. I would now like to hand the conference back to today's presenter. Please continue.
Thank you for everyone for taking time to participate in this call. We really look forward to receiving your comments. And again, thank you for your willingness to submit them on such a short turnaround track. But we really are trying to get this guidance out. Now that we're in a new administration, fresh, not even 24 hours old. We want to get as many things as possible we've been working hard on with you out as soon as possible. So we look forward to receiving them. Thank you.